Let's start, man. Yes. Good evening, everyone. Welcome you all for yet another What is the Expertise session. Today, we have an interesting topic that commonly discussed in our setup is SUDER by Dr. Rajesh Naik. The request of President Shafali ma'am to introduce the speaker for today, the experts for today's session, and the moderator for today's session. Over to you, ma'am.
Yeah, thank you. Thank you, Mahesh. Welcome you all and reminding you to register and send your abstracts for the AOCCN. They are on. Symposia proposals will be sent out shortly. Can I have the slides, please? Smita, with speaker introduction. Today we have a very wonderful speaker, Dr. Rajesh Ramachandran Nair, is professor in the McMaster University, Hamilton staff neurologist and epileptologist at the McMaster Children's Hospital, Canada. And he has lots of qualifications and affiliations. And his research focus is on epilepsy, especially its SUDAP communication, ketogenic diet, and EE-SWAS. He is the founding program director of the ICNC teaching ICNTN teaching network of ICNA and serves on the ILE Adapt and Implementation Task Force and the Scientific Program Committee of American Epilepsy Society, and is the lead author of the Provincial Guidelines on the Management of Epilepsy and the founding program director of the Canadian Epilepsy Teaching Network at the McMasters. Thank you, Dr. Rajesh, for joining. Welcome to this webinar series. And as usually, we have from different resource settings, we are going to be having experts. Dr. Suresh Pujar, who is a consultant pediatric neurologist at the Great Ormond Street Hospital for Children, UK, and honorary lecturer at the UCL, and chair of the British Pediatric Epilepsy Group, and chair for the UK Pediatric Epilepsy Program Board. He's done PhD in MRC-PCH, and his area of interest are status epilepticus, Fires, Rasmussen, complex epilepsy, epilepsy surgery, ketogenic diet, and transitional care. Thank you for joining. We have Dr. Faisal Zafar, Assistant Professor in Pediatric Neurology, Children's Hospital and Institute of Child Health, Multan in Pakistan, with MBBS, FCPS and FCPS in Pediatric Neurology, with the area of interest in neurodevelopmental issues, neuromuscular disorders and epilepsy. Thank you, Dr. Faisal, for joining. Then we have our dear friend, Dr. Mary I. She's Professor and Head of Department of Pediatric Neurologist, Government Medical College, Trivandrum, and Regional Director and Visiting Professor on Institute of Communicative and Cognitive Neurosciences. And she's MDDM with lots of other additional fellowships, and has got the Best Researcher Award and a gold medalist and President of India medal and lots of accolades. And she's a wonderful professional and an amazing human being. Thanks, Mary, for joining. And for moderating the session, we have our own alumnus, Dr. Lakshmi Narayan Kanan, Senior Consultant Epileptologist and Pediatric Neurologist at the Advanced Center for Epilepsy, Glen Gales Global Health City, Chennai. And who, as I mentioned to you, our alumnus, and his interest area is complex pediatric epilepsy and epilepsy surgery and stereo EEG, and is member of ILA Pediatric Epilepsy Surgery Task Force and ILA Epilepsiom Task Force, and is a national convener, Young Epilepsy Section and the Indian Epilepsy Society. Over to you, Dr. Lakshmi Narayan, for taking it.
Thank you, ma'am. Without further ado, this is one of the most important topic. But saying that it is the most important topic, most of the times this is not being discussed with the patients as often it should be discussed, especially those patients who are drug-resistant epilepsy, because we know there is a real risk of SUDEP occurring in drug-resistant epilepsy, especially if they have convulsive seizures. So it needs to be communicated and brought on at some point, even though not on the first visit with the patient, but at some point this should be communicated. The best way to communicate is to have a brochure so that brings on the topic and the families come to you asking for this. So, and the more often the neurologists and the epilepsy doctors need to talk about this. So let us hear this from the expert, Dr. Rajesh Ramchandran Nair. Over to you. Over to you, Rajesh.
Can you see my slide?
Yes, sir. Yes, sir.
Okay. Thank you so much for the introduction, Dr. Shafal Gulati, and thank you for the kind invitation. It is a real honor and privilege. This is me, and these are my academic disclosures. I have received funding from both government as well as non-government organizations for conducting research in Sweden. So as always, I am sure that some of you have already seen my slides because this is what I taught for the past 5 years. So what is the predicted course in this 11-year-old girl who has been having recurrent staring spells for the past 6 months, and EEG showed generalized 3 per second spike and wave discharges? Patients' seizures were controlled on ethosuximide. So we know that this is a typical case of absence epilepsy, but the age is 11. Now let us see another 17-year-old young man who has been having recurrent focal seizures for the past 4 years. Is characterized by focal seizures with impaired awareness progressing to bilateral tonic-clonic movements. They happen multiple times in a week and is already on 3 anti-seizure medication. What would be the predicted course you guys would think, and have that formulation in your mind? You don't have to write it in the chat box. Now, so for agenda for today is what is the definition of SUDEP? What is the incidence? What are the risk factors? And more importantly, the mechanisms, because unless you know the mechanisms, you won't be able to find a preventive strategy. Mortality in epilepsy is the standardized mortality ratio. I hope everybody knows what is standardized mortality ratio. Is the mortality during a defined period of time, say for example, within a period of 1 year in a defined disease population compared to the general population. So compared to the general population, the SMR for epilepsy is high, that is 2.3. And the SMR is high in in children with epilepsy, most likely because of the underlying etiology, because they may have cerebral palsy secondary to HIV, genetic causes. and what all comes along with is recurrent aspiration, infection, those things. People with epilepsy are more likely to die prematurely from epilepsy-related causes of death. So the term prematurely is very important, that at a younger age. So SMR for epilepsy-related causes are 3.8 and non-related causes are 1.7. So non-related causes might include somebody committing a suicide. So the implication of epilepsy on life depends upon the underlying etiology and the comorbidities. You can see in this picture that there is a tumor which is rapidly progressive, whether the patient has epilepsy or not. Just because of the biological nature of this tumor, there is high mortality. Epilepsy-related causes are prolonged seizures, otherwise known as status epilepticus, drowning, accidents during the time of a seizure, and more importantly, SUDEP, which is otherwise known as sudden unexpected death in epilepsy. Back to our patient. So this was the first patient, who is an 11-year-old girl who has been having staring spells for the past 6 months, generalized 3 per second spike and wave discharges, seizures controlled on ethosuximab. 1 year later, she passed during sleep in the prone position, and there was evidence of conversion as evidenced by frothing from the mouth and how the bedsheet looked like. So there was evidence of conversion. An autopsy was done, and there was no anatomical or toxicological etiology attributable to the death. So that is precisely sudden unexpected death in epilepsy, which is unexpected as well as unexplained in a person with epilepsy. So it's very important that person should have had a previous diagnosis of epilepsy unrelated to trauma, drowning, or status epilepticus. It could be witnessed or not witnessed. Evidence of a preceding seizure is not necessarily required, but often assumed. Postmortem examination does not reveal a cause for death, anatomical or toxicology. So coming back to our patient who was 11-year-old, absence epilepsy, after 1 year died, satisfied the criteria. Even a toxicological analysis was. But somebody at the time of autopsy was curious enough to gather the postmortem tissue for a genetic study. And the postmortem genetic test showed a sodium channel mutation, a pathogenic mutation, SCN5A. And what does SCN5A cause? Both the gain of function as well as the loss of function can cause cardiac arrhythmia. A classic example is Brugada syndrome. So she had this particular mutation, which was unidentified. So the question is, would you call it SUDEP or something else? As of now, as per the definition, this is SUDEP. So what does it mean? The concept of SUDEP definition is not foolproof, and it is phenomenon-based and not necessarily a mechanism-based or etiology-based. So if somebody has a cause like the SCN5A, we call it definite SUDEP plus. That plus indicates that there is an additional etiology that could be contributing to the death. Now, what are the challenges with this definition? What about febrile seizure? Suppose a child had 3 febrile seizures, and on the 4th febrile seizure, which lasts for about 10 minutes, passed. Would you call it SUDEP? The seizure is an epileptic seizure, but it does not satisfy the definition of epilepsy. So by definition, this is not SUDEP. But think about the mechanisms that all the epileptic post-ictal mechanisms will be in play here as well, but we don't call it SUDEP. Following the first conversion, somebody can have a first conversion and can pass, and the etiology, the mechanism could be the epileptic post-ictal phenomenon. What about status epilepticus? If somebody had a seizure for 20 minutes and passed, you can call it SUDEP. But if it is 31 minutes, you don't call it SUDEP. So there is some sort of confusion regarding the definition of SUDEP. And the International ILA Task Force on SUDEP is working on refining the definition of SUDEP, and I think that there is a lot of controversy. I had opportunity to talk to one of the task force members, and they were wondering, should you even include the term unexpected and replace with the unexplained? Because we know that certain population of patients with epilepsy are at high risk. So when it's known that such a risk exists, would you call it unexpected? Well, let them sort it out. Now, the myth is SUDEP is rare and even rare in children. So what is the definition of rare in mortality? If somebody dies and you compare that with somebody having common cold or a disease like that, it doesn't really make sense to make a comparison in terms of the actual incidence, because mortality is a catastrophic event. So we express the incidence of SUDEP in terms of the patient years, which means if you have 100 patients and you follow them for 10 years, you have a cumulative 1,000 patient years. If you have 1,000 patients and you follow them for 1 year, it also means 1,000 patient years. So in adult population, irrespective of the recency of the diagnosis or the complexity or the severity of epilepsy, it is generally 1 in 1,000 patient years. If you are talking about drug refractory epilepsy, especially convulsive, it could be as high as 100. That means if you have 1,000 patients with the drug refractory epilepsy, in a 1 year period, you are likely to lose 10 patients to SUDEP. That is a pretty high number. And we will discuss our risk factors in a bit, but recurrent nocturnal convulsions, male sex, young adults are more prone. Initially, people thought the risk of SUDEP in pediatric age group is 1/10 that of the adult. This has been disproven by my colleagues from Toronto, and this was published about 6 years back, and that the incidence is exactly the same. That is 1.2 per 1,000 patient years. So whether you are an adult or a pediatric patient, the risk of SUDEP is same. The only challenge is probably this is grossly under-recognized, because when I was a medical student and a resident in India, we always used to write cardiorespiratory arrest. Well, who doesn't die without that? But the real cause for death is something different. Now, let us look at the magnitude. So this was from 2005. This is from the United States and from CDC criteria. And that says the number of death in 1,000 is in the y-axis, and in the x-axis, you have the neurological condition. You can see Alzheimer's disease, that particular year, 83,000 people died, whereas only 3,000 people died due to SUDEP. Well, you can argue that, well, that is a microscopic minority, like just 5% of Alzheimer's. Well, I really want you to look at it in another way. Here, the x-axis is years of potential life lost. So, the stroke is the #1 leading cause of years of potential years of life loss. That is 187,000. The second most common neurological cause is SUDEP. It is nearly 100,000 per year. The reason is SUDEP happens in the younger population. So with all due respect to people who are chronologically gifted, we don't want anybody to die unnecessarily. So in Alzheimer's, when they die, they are already in their 70s or 80s, so that the potential years of life lost is lower. Whereas if a person dies in the younger age group, the potential years of life lost is very high. So how can somebody say that this is rare? I don't think so. Now, certain type of epilepsies we all know as pediatric epileptologist and neurologist, 16-year-old girl, history of febrile status epilepticus, then afebrile seizures, occasional myoclonus, which were later replaced by GTCs and developmentally delayed, later developed Parkinsonian gait. EEG showed a generalized spike wave. We know that this is the classic phenotype of a teenager with Dravet syndrome. In Dravet syndrome, the risk of SUDEP is high, mainly because of two reasons. One, the risk of high number of convulsions, and the second one is the sodium channel mutation is expressed in the SA node as well. And during the tonic phase, studies have shown that there is a significant bradycardia, and longer the period of the tonic seizure, higher the risk of mortality. The million-dollar question is, why does SUDEP happen? The circumstances about the death of SUDEP victims have shown that majority were unwitnessed, and the victims were found in the prone position, and there was evidence of convulsion, and majority happened during the night time. So that brings us to the eternal debate whether it was a heart that stopped first, was it the breathing that stopped, whether it is a brain shutdown so that everything else is shut down, or there is a genetic etiology. What is the role of serotonin, and what is the role of adenosine? The first and foremost, I think this is a very old paper from 2011 years old, but I would say this is the best paper in this field. This is about the incidence of SUDEP in epilepsy monitoring units in Europe, Israel, and New Zealand and Australia. We know that when patients are admitted to the epilepsy monitoring unit, there will be video, there will be an EEG, there will be an ECG lead, and you can really watch the respiratory movement through the video. And they had 11 patients who had SUDEP. And look at when it happened. Out of the 11, 9 happened at night. So what does it tell us? Things happen at night, even in the best hospitals. And what is EPIN? So let me explain. These authors describe this as early post-ictal neurovegetative breakdown. That immediately after the seizure, you can have a chaotic breathing pattern as well as a respiratory pattern. That initial breakdown is known as early post-ictal neurovegetative breakdown. So they demonstrated majority neurovegetative breakdown, but if you really look, you can see that the terminal event is asystole, but in majority there was an apnea, terminal apnea that preceded the asystole. And look at the time to intervene. So these happened in the hospital. So seizure happened. The earliest somebody intervened was 13 minutes. And the longest was 3 hours. So patient had the seizure, probably already dead, and nobody in the nursing station really realized that. So what does it tell us? For those who died, majority happened at night, and in majority it was the terminal apnea that preceded the asystole, and there was no intervention. Whereas they identified 9 patients with near SUDEP. Near SUDEP means they almost lost the patient, but was successfully resuscitated, and the patient survived for 1 hour. So that is a definition of near SUDEP. And look at out of the 9, how many happened at night? Only 3 happened at night, means 2/3 happened during the daytime. It tells us that if you really want to survive, you should develop a seizure during the daytime. But look at the time to intervene. I think all of them were, there was an intervention from the nursing staff or the healthcare staff within 3 minutes. What does it tell us? Okay, let us show the SUDEP graphic representation of 9 patients. What we can see, what is in red is the heart rate. And what is in blue or teal, I think this color is known as teal, not blue. You can see that the respiration stops first before the heart rate stops. So it has proven that in majority, it is the terminal apnea which is important. So in summary, resuscitation is important. That means supervision is important. And terminal apnea is probably the terminal event. So just to reiterate, a terminal seizure. The seizure discharge spreads to the brainstem. It also releases adenosine and opiates because these are anticonvulsants. So for the brain to protect against propagation of seizures, they release endogenous adenosine and opiates. And what they do, they suppress the ictal center. That means the respiration will be compromised. So this is a double-edged sword. On one hand, they are anticonvulsant, but on the other hand, they are respiratory depressants. So in other words, during a seizure, you can have a peri-ictal turning to the prone position. Even if the patient is sleeping in the supine position, you turn to the prone position, and what happens? It affects your automatic recovery, and it adds to the obstructive sleep apnea as well. So you have a central apnea, you have a position that compromises your recovery, and then in many patients, you can have a central as well as obstructive apnea as well. We will discuss it later. On top of that, you have impairment of ascending arousal projections because nobody is intervening. And the EEG might show a post-ictal generalized EEG suppression, otherwise known as PGES. That means the brain shuts down. We know that during seizure, you can have significant cardiac dysarrhythmia. So all of this probably contributes to SUDEP. But a very interesting concept put forward in the last year was this mechanism, and this is heavily geared towards SUDEP following a convulsion. So this is just based on, we know that even without convulsion, sometimes you can have SUDEP. So what they are trying to show here is in the brain, one is there is a seizure. It's a cortical phenomenon. And what does the brain do? Brain releases adenosine. And what does adenosine do? Adenosine acts on the rostroventrolateral medulla. Rostroventrolateral medulla. And that is where the adenosine acts. And it inhibits the rostroventrolateral medulla. And then it reduces the input to the serotonergic raphe nucleus in the midbrain. So when the serotonergic nuclei in the before that rostroventrolateral medulla, it is a respiratory center, and that suppresses the respiration. You can see that. So that triggers apnea. And when you have apnea, what happens is the blood carbon dioxide level will increase. The serotonergic raphe nucleus in the mid pons is highly sensitive to increase in blood carbon dioxide. And what does it do? It releases serotonin, which acts on the periactive ductal gray matter, which in turn activates autoresuscitation. So if you have an impairment anywhere in this pathway or multiple areas, potentially you can get SUDEP. Now the question is, did we get the final answer? I would say no. This is probably not a unifying hypothesis because this is applicable only following a conversion. And in the Mortimer study, which I already described in the EMUs, only 67% had a preceding apnea. And what about the rest? Were they undetected, or was there any other mechanism? And we know that during seizure, you can have a laryngospasm, and that can induce an obstructive apnea. And during many seizures, you can get a post-ictal generalized EEG suppression that can suppress your brainstem autonomic centers. And we know that there is an autonomic dysfunction and cardiac arrhythmia. So a significant number of patients who had SUDEP could be explained on the basis of the adenosine serotonin mechanism, but probably not all, because it is not a synthetic mechanism. Well, now comes, well, we have all these, but how are you going to reduce the risk of SUDEP? First and foremost is appropriate anti-seizure management. Timely pre-surgical referral is extremely important because when two drugs fail to control seizures, the chance of success with the third drug is only around 20%, not 5%. Because that original article from Martin Brody and Patty Kwan had some statistical issues. So 20%, that is a success with the third drug. Well, in a carefully selected surgical patient, your seizure freedom is as high as 60 to 80%. So it is not a match. So any patient who has failed two appropriately selected anti-seizure medication and has focal epilepsy should be referred for timely pre-surgical management rather than sitting on. And surgery in suitable candidates is highly effective. If the surgery has failed, there is a higher risk of SUDEP, not because the surgery, but because they continue to have higher number of seizures. Patient education is very important, drug compliance, lifestyle measures to avoid sleep deprivation, stress, excess alcohol, and have a plan for home management of seizures. Now, that brings to our major topic. People believe that patients and families do not want to hear about SUDEP. Well, there are proponents of a right to know. Yes, patients have the right to know. And all the advocacy groups have mentioned that the patient should be informed about the risk of SUDEP. And we have enough studies to show that they really wanted to hear about SUDEP. And interviews of bereaved relatives have shown that they were angry and shocked and upset that they were not informed about the risk of SUDEP. Now you have, there are two sides. People who believe that there is a right to know also say, not also, the other group says that then patient may have a right not to know. Say, for example, if you do a genetic test and patient may say, I don't want to hear about the risk of Huntington's disease or Alzheimer's disease, well, that is within their purview as well. And the physicians can exercise something known as therapeutic privilege. Therapeutic privilege is something when the physician deliberately exercise in order to protect the patient's well-being. Well, I can say that probably that is a paternalistic attitude as well. So there are different sides to the same argument. So what should we do? We should ask the experts. Who are the experts? We thought the experts are the actual patients or caregivers of patients with epilepsy. Being a pediatric epileptologist, I started this was published more than 11 years back. Parents' opinion. Well, then I became curious, and then I extended that to the adult patients. I involving recruiting patients from the adult epilepsy clinic from our university hospital. Then we also did the same study with actually bereaved relatives. You should all understand that this was done in North America, and all these patients were seen by a neurologist. So they were already biased. And their opinion was all of them wanted to be unanimous. So this is a qualitative study, not a quantitative study like a survey. So we do focus group interviews and in-depth one-to-one interviews. There was unanimous opinion that everybody wanted to hear about the risk of SUDEP. When majority wanted to hear about the risk of SUDEP at the time of diagnosis, probably because they know that in the North American system, to get the second follow-up, it might take several months. But there were a few groups who said that at the initial visit, they might be overwhelmed with all the prognosis, diagnosis, medication information about epilepsy, that they wanted to have this discussion in the closer follow-up. So irrespective of the timing, all of them wanted to hear about SUDEP. And what did they want to hear about SUDEP? Ideally, something specific for that patient, not a general information. And they wanted it face-to-face, and they hate it when it is given through a brochure. And it should be part of a comprehensive epilepsy counseling, not as a separate stand-alone pamphlet or a document, which we never recommend. Now, another myth is, well, you have provided this study, but we believe that if you discuss SUDEP, that is going to create unnecessary anxiety in my patients. Well, which physician wants to create unnecessary anxiety in their patients and families. So what should we do? We did another qualitative study. We recruited patients with epilepsy and caregivers of patients with the epilepsy who were informed about the risk of SUDEP at least 12 months prior to the interview. That means we have 12 months to see how the information or the risk about SUDEP influence their life. Well, in a few, initially there was some stress and anxiety, but over the long term, everybody appreciated informing about the risk of SUDEP, and there was no long-standing anxiety or mental health issues. It again empowers the healthcare provider to approach the disclosure about SUDEP with some confidence. Well, this study was done in the pediatric age group from New Delhi, I believe. When families were informed about the risk of SUDEP in a substantial number, it changed the behavior and practice in more than 2 epilepsy childcare behavior practice. It could be administration of anti-seizure medication on time, having a seizure plan, rescue medication, providing information about child's epilepsy to the school, and giving a seizure action plan to their school. So that means giving the information about SUDEP in this small study showed that there can be some positive benefits. This was replicated in the adult population, and they have shown that providing information about SUDEP did not adversely affect the quality of the life or the mood, but there was a tendency for better drug adherence, but you need a larger population to really study the impact. Now, how can you evaluate the success of a SUDEP prevention modality? Well, even in the rarest of the rare, it is about 1 in 100 patient years the risk. That means if you really want to have a new intervention modality and you want to provide that intervention for 6 months to reduce the incidence of SUDEP by 50%, it requires a sample size of 12,000 patients. And you are not going to get 12,000 patients with SUDEP. So it is just impossible. I thank my colleague Suhasini Sharma for giving me this statistical problem. Well, can we identify patients at risk? As I already mentioned, I don't believe in the SUDEP 7 checklist because it has not been consistently reproduced, but it gives you some idea about the risk. If you have more than 3 GTC in the last year, the odds of dying with SUDEP is 8 times. And if you have more than 50 seizures per month over the last term, any type of seizure, whether it is a convulsive or non-convulsive, it is 11. Longer the duration, higher the chance. And if you have a developmental challenge, your risk is high. So think about your patient population, your clinic patients with multiple seizures, developmentally challenged, their risk of SUDEP is going to be high. And we were asked to write a review on the genes, and we were really not able to come up with any idea about who is at the highest risk, or how can we predict the risk based on the genetic analysis. We are not there yet, but we identified certain genes which are more commonly identified in victims of SUDEP. Now, this is, I am sure that all of you have seen this. This is the post-ictal generalized EEG suppression, and usually seen after GTC. And if this is more than 50 seconds, it gives a very high risk of SUDEP. Now, coming back to nocturnal supervision, when I talk to my colleagues from India, they say that, oh, well, you are inflating the real risk of SUDEP. In my practice, I have never seen a case of SUDEP. 2 reasons. One, probably you don't have the longitudinal follow-up on every patient. Second, I think the death is recorded as cardiorespiratory arrest and the postmortem is probably not done. And the third, probably important one is there is a habit of child sleeping in the parent's room, and probably there is some resuscitation mechanism. These are all postulations, but that is possible. Now, in order to prevent, first you have to identify the seizure. So there is millions of dollars devoted in gadgets that will help you identify seizure in time. So it could be the EEG could be a marker, the sound, or it could be variability in the heart rate, or it could be a muscle contraction because convulsion or movement, breathing and oxygen saturation, skin conductance. We know that the skin conductance temporarily increase due to the autonomic activation, and you can combine one or any of those to a wearable option. Now, these are electroencephalography. If you have like a 2-channel EEG, it's quite inconvenient. You can see that it can pick up the changes. Blood saturation during a convulsion seizure, that is shown in Peel. There is a dip. The heart rate in convulsive seizure can increase. The movement, there will be chaotic. Convulsive seizure is actually in, it's called orange. I'm going to orange. A movement you pick up, and electrodermal activity actually increases. So if you combine any of this, you can identify seizure with reasonable accuracy. So these are the FDA approved ones, the first two ones. It is a seizure detecting wrist-worn digital health technology. So DST is digital technology. It could be an accelerometer, electrodermal activity, or a skin temperature, or an armband, which is electromyography with or without accelerometer, and photoplethysmography. Photoplethysmography is you identify the blood flow changes. Well, everybody uses, well, I cannot say. It is very popular that you use an Apple Watch. So this title is a bit misleading because what the researchers did was they put an Epi Watch, that is a software that incorporates three-dimensional accelerometer as well as photoplethysmography into a software and put that in the Apple Watch. And when they conducted the analysis, the pickup of convulsive seizure was 100%. And we are always worried about the false alarm rate, that for no reason it goes on and we become panicked. Well, the false alarm rate here was less than 0.1 per 24 hours, and any false alarm rate less than 0.2 is excellent. So Apple Watch, well, is not yet approved, but if you put the Epi Watch software in it, it could be useful. These devices are marketed in a way that they can prevent against SUDEP, but there is no evidence. But it is logical that you can recognize seizures. Some of them really need a monthly subscription and cost. But what the ILA has recommended that you can use or recommend a wearable device for automatic detection of generalized tonic-clonic seizure or focal becoming bilateral tonic-clonic when all the following conditions are satisfied. When there is a safety concern because frequent seizures, especially in unsupervised patients who do not share a bedroom, but when the alarm results in intervention in 5 minutes, there is no point in marketing that, hey, when your son is in college in a university in a different city, you can really detect this. There is no use. Only if the intervention can be done within 5 minutes. Now, prone position and SUDEP, I will never recommend my patients with epilepsy to sleep in the prone position. But the trouble there is probably the prone position is an ictal turning. So even if they are sleeping in the supine position, they might turn peri-ictally to the prone position. But we will never ask them to sleep in the prone position. This is almost like the sits, isn't it? Safety pillows, very interesting, but there is no studies available. They say that when they are in the prone position, they can actually breathe through the lattice pillow. I'm not entirely sure, but it is available in the market. And in the EMU, I think all EMUs, especially when you taper the drug, you should have a safety for EMU. Last few slides, serotonergic drugs. A retrospective study has shown that patients who are receiving SSRI, their post-ictal hypoxemia was significantly less. We know that depression can be a comorbidity of epilepsy, so feel free to use SSRI if the patient has depression. Epilepsy is not a contraindication. There is a study which was started about 12 years back in France. The results are not yet available. I think they had a significant problem in recruiting patients. So what they were trying to do is a placebo control. In fluoxetine group, they were trying to see the percentage of post-ictal hypoxemia. This is very interesting because during seizure, somebody is calling me, but I'm not answering, don't worry. Naloxone may potentially reduce the occurrence of post-ictal apnea because that is an inhibitor of endogenous opiate. We know that opiates are released during seizure and that can suppress the respiratory center. And again, the RCT on naloxone, the results are not yet available, but there is a study from India that shows this study can be done as a pilot project. Adenosine. Caffeine is an adenosine antagonist. So you may wonder, why don't we just prescribe caffeine and espresso, lots of espresso? But the trouble is, it is an adenosine antagonist, can protect against post-ictal hypoxemia, but it is a proconvulsive. So it's a double-edged sword. So we were asked to write about prevention of SUDEP, and all those things I described so far, we put it there. So this is just a summary of the preventive strategy. I am not going to go through it again because we already discussed. And this is more recent. All of them we discussed, but we believe that when you feed in multiple patient characteristics into the AI, probably they will be able to give you an exact risk. More importantly, estradiol is a drug that is used in Parkinson's disease, and that is an adenosine blocker. Probably in future, it can be repurposed. So this mechanism, again, convulsive seizures, release adenosine. Adenosine depresses the medulla. It causes hypopnea that raises the carbon dioxide, triggers the serotonergic neurons in the raphe nucleus that activates the periaqueductal gray matter, and you get resuscitation. And if there is an impairment, you get SUDEP. Summary, SUDEP is not rare, depending upon your definition or concept of rare in mortality. Definition is not entirely based on mechanism. And the mechanism, we believe, majority of them is terminal apnea. Counseling is very important, and it does not increase long-term anxiety. And prevention, we are not there yet, but there we can do several things to reduce the incidence of nocturnal conversion. Thank you so much, and this is my acknowledgement.
Thank you, Rajesh. That was a comprehensive talk on SUDEP, especially with evidence-based interventions, as well as how to detect the seizures and seizure alarms, and more importantly, the SUDEP communication, when to communicate, how to communicate. I think most of us gained good knowledge base from your excellent talk. Thank you for that. Let us hear from other experts. What is their anecdotal experience with SUDEP in their patient population, and how do they communicate SUDEP with the patient, especially the high-risk group of drug-resistant epilepsy. Let us hear from Dr. Suresh Pujar. So can you share anecdotal experience and how to communicate SUDEP, and how do you do it?
Thank you, Lakshmi. So there's a lot of work going on currently in the UK with regards to SUDEP communication. There is a charity called SUDEP Action who are taking the lead, and we are all several of us stakeholders are involved, including epilepsy charities and patient groups and parents and bereaved family members. They're all involved in these discussions, and what's happening is development of a seizure safety and SUDEP checklist to identify patients who are at increased risk of having SUDEP. And there is a lot of emphasis on communication. So I think that's one thing that is really lacking across the board, especially in the UK, and it's mainly because of time pressure. So we all have a certain amount of time in our clinic to see the patients, go through the history, and make management plans and everything. And on top of that, to have a discussion around SUDEP, which is needs to be dealt with in a sensitive way, isn't it? And then you can't just kind of mention about SUDEP in 1 or 2 minutes and then confuse the patients and the parents and then kind of not say more. So that will cause more anxiety. So it needs to be kind of communicated in a way so that you give them the information, but also kind of follow that up with something more. Otherwise, I think it causes anxiety that way. So we kind of say that this discussion needs to happen with all patients with epilepsy, not just those who are high risk, because as you showed, Rajesh showed there, I mean, a patient with absence kind of seizures had a SUDEP. So, and we know that there are kind of rare cases of even, Rolandic epilepsy who've had SUDEP. So it's not necessary that SUDEP only happens in severe. Of course, the risk is much higher in them, but the risk is there in all. So the strategy I use is basically start talking about the risks of seizures, kind of saying the first time you had a seizure, you thought your child was going to die. And from there on to, depending on the risk, I kind of tailor the conversation to kind of either reassure the parents to kind of say that, yes, there is the risk, small risk that a child might die during a seizure, but fortunately for this type of seizure, the risk is lower, and then talk about what can be done to reduce the risk in that group. And in the other extreme, where they are having drug-resistant epilepsy and with high seizure burden and with tonic or tonic-clonic seizures from sleep and teenagers, and especially if there is any question about compliance to medication, then I use that discussion to kind of say, well, I mean, if you don't comply with treatment, with the type of seizures you have, the risk of SUDEP is really high. So that kind of gives them the context and hopefully kind of improves compliance. So yeah, I mean, Rajesh did talk about whether you're making some patients more anxious by giving information, and whether it's causing more anxiety and sleepless nights to parents. But generally that is not the case. And again, there is a lot of data to suggest that they would rather want to know about it than not knowing about it. But again, it depends on the context that you give the information around, and it can be used to kind of even reassure parents and patients, but at the same time, provide the information that they need to know.
Yeah,
Thank you,
thank you
Suresh.
for that.
Before Lakshmi, you go to our low resource settings, I would request Dr. Kothari to tell what he practices in New York about it, because that may guide the further discussion coming to the lower resource. Dr. Kothari, please. Thank you for
Thank you
joining.
so much. And a very comprehensive lecture given. We have written several papers on SUDEP review as well as original articles. But I want to emphasize a couple of things. Number one, people used to think that SUDEP happens only in 20 to 40-year-old adults. That's not true. We wrote an editorial based on 2 papers, one which came from Canada and one which came from the Scandinavian countries, that the SUDEP risk is the same 1 in 1,000, whether it's children or adults. The reason why it was thought less likely was the data was not properly analyzed. The Canadian group really from Sick Children's and other areas in Canada did a very nice analysis looking at multiple databases, and they found that the prevalence of SUDEP in children also is equal. Also, SUDEP risk continues even after seizures have stopped, and it can happen even in benign Rolandic epilepsy. So there are lots of newer details which have come out. I've written an editorial on that in Neurology on this. And the other thing from New York standpoint, so we are the only state in America where it is a mandated law that the epileptologist or the neurologist, the primary epileptologist or the neurologist who's treating the patient, has to discuss with the family about the SUDEP risk and it has to be put in the EMR that you discussed it. Failing to do so, it amounts to almost having a criminal offense. So it's a big responsibility that has been placed on us by our governor, and we have taken due precautions that we do not lapse on this thing. So the way we do it is we keep pamphlets in the waiting room. We keep pamphlets in every room, and when the patient comes in, we just tell it is our mandate. So have you read this pamphlet about SUDEP risk? And we would like to discuss that with you. Do you want more information? And I think I've never had any angry parent, any apprehensive parent ever walk away from there. So I think it's a misnomer that people feel anxious. It's the physician who feels anxious, not the patient. I've given talks at the PAMI, which is the Prevention Against Mortality in Epilepsy conferences many times, and families have spoken to me and said, why didn't my doctor discuss this? We would have been much more knowledgeable and experienced to prevent these things. So that's one thing I'd like to emphasize. Secondly, we do ask our patients to buy the rebreathing pillows. They're available in the US for $88. They're not very expensive, less than $100. And you can breathe through them when you're in the prone position, and it may be the only thing that will save your life. Also, I think one of the issues that was discussed was the post-ictal central apnea, but also along with that, you have hypoventilation. And the hypoventilation we measure during our video EEG monitoring with transcutaneous CO2 and end-tidal. The problem is the end-tidal CO2 drops off. The transcutaneous CO2 does not. And so we have clearly shown the surge in CO2 happens around the seizure, more with tonic seizures, and it goes on increasing for several minutes. And that causes the brain shutdown, which causes the PGES, which causes further cascading events. Lastly, adenosine, everybody, we know that adenosine is an anti-epileptic. So is that why? The simplistic answer is adenosine levels drop as soon as we fall asleep. And is that why we get seizures with sleep, onset of sleep? But that's a simplistic answer. In chronic refractory epilepsy, adenosine becomes a two-way street, and it can actually cause epigenetics and transmethylation defects, which further perpetuate refractory epilepsy. So it's not a simple thing. You know that adenosine's half-life is very small. So therefore, you cannot give adenosine to prevent SUDEP risk. You have to use agents to decrease its metabolism. So use ADK antagonists, which have been considered. But there is a lot of debate going on about how to use them. Also, there are adenosine 1 receptors and adenosine 2 receptors. And the cortical receptors act differently as compared to the brainstem receptors. And that's where the other problem. Caffeine works on the central ones, and it can actually worsen central apnea. So it's very tricky, this whole business about SUDEP, but clearly it happens in children. One other thing I'd like to emphasize, the speaker spoke about serotonin. So in pediatrics, we have a drug called Fintepla, which is fenfluramine, and it is a 5-HT2ABC antagonist. So it definitely works in it works in increasing 5-HT, which increases serotonin. And we have a paper that we published that in people who were using Fintepla, which is approved for LGS and Dravet, the SUDEP risk dropped tenfold in the Dravet population. That paper is published in one of the European journals. We looked at the Fintepla data from the company on 300 patients, and it was very robust. So I use Fintepla off-label in almost all my DEEs, all my developmental epileptic encephalopathies, because of the risk of SUDEP reduction that happens with it. So those are a few of my comments.
Thank you so much. Lakshmi, take on, please. Continue.
Yeah. So now let's hear about what's the experience in Indian subcontinent. So first, I would like to ask Dr. Mary Ayub. Like, ma'am, have you come across any anecdotal patients with the SUDEP, and how did you handle, and how do you go about the communicating about the SUDEP? Because communicating SUDEP in Western population is slightly different compared to our population, who are a little bit more sentimental, especially more sentimental about not hearing about death or not talking about death. So how do you do this?
See, that was a masterly exposition by Dr. Rajesh.
One thing that he pointed out was in India, we do not longitudinally follow up all these children. That must be the reason we do not recognize SUDEP in India. Because recently we did a follow-up study in children with infantile spasms. In children with infantile spasms for a short period of time, we had 160 of them, 19 of them died, and 2 of them fulfilled the criteria for SUDEP. So unless we had followed them up, we would have never recognized that there were 2 children who had died in circumstances that could certainly be certified as SUDEP. We have published it in the journal Seizure. And then, as already pointed out, in India, the children sleep with the parents. As soon as there is a small slight movement, the mother wakes up. And it is not only the practice of sleeping with the child, this is also the commitment that the mother has to a child. I think it is certainly different from a Western mother. The mother will immediately know what has happened. She'll wake up totally and do what is necessary for the child. That must be the reason. The major reason, I think, is because we are unaware of all the SUDEPs. Especially because after that study that we have done, I am convinced that it is because we are not following them up. Then about telling them about SUDEP, we have read about it, we have heard about it, and now I have heard that it's a legislation in the US. It is not practical in India. Because I work in the government setup and I see around 200 patients in a day. How can you just cannot tell them about their disease, the medication adherence, etc. How can we embark on SUDEP in this small span of time? So I think after this, I will try. But to date, we have not done that. Not only that, we are not aware that these people are having SUDEP also, other than in this study.
Thank you, ma'am. Dr. Faisal Safar, what's your experience with SUDEP and SUDEP communication, and how do you go about this? Dr. Faisal? I think you are
You're
muted.
muted.
Please unmute. Yes, sir.
Hello. Can you hear me now? Yeah.
Yes.
First of all, a wonderful presentation by Dr. Rajesh and very well elaborated. The thing is this, that obviously as a pediatric neurologist, we are dealing with most of the patients with a kind of refractory epilepsy, and with respect of their causes, obviously those developmental delays child which are having other systemic possibilities as well, along with those recurrent infection as well as the cases of developmental and epileptic encephalopathies, because they are mostly having usually more than two anti-epileptics in the combination, and the patient is having multiple episodes per day, which usually, and most of the patients who belongs to lower socioeconomic status, and they are having recurrent concomitant infection as well. As Dr. Mary told that in these settings, it is clearly not possible to know the exact cases of SUDEP, because most of the time patients used to come whenever they have 2 or 3 siblings involved with a similar kind of problem, or there's some cousins having this problem. They came to our follow-up and they used to tell that the other sibling which was on our follow-up die of the sudden this experience. But obviously at that time they are unable to reach the tertiary care hospital, and by collecting all the information from their primary physician and nearby hospital, definitely those having kind of respiratory issues as well as the hypoxia, which causing these kind of SUDEP as well. But regarding the information and counseling with the families, we noticed that they don't have that much apprehension about this. Obviously, we need to counsel them regarding the proper compliance so that this risk can be minimized. Obviously, we do the counseling and the session as well. For this, it can be helpful to our well-educated families, but not that too much extent in the lower socioeconomic and uneducated families that is not properly being monitored and having good follow-up.
Thank you, Dr. Safar. Oh, there's a
Lakshmi,
question
can we
from the-
have the case? Lakshmi, can we have the case because there's only one case and then we can go to the Q&A and complete. One case is there, no? So can we have that case?
Yes, ma'am.
Yathvin is there, huh? Only one case is today there, so we can have And this also shows we have so many cases every time, and SUDEP is not recognized that much, and that is what Mary was saying, because we are not looking for it, and it is obviously there. So we can just have this quick case, and then we can continue with the discussion. Yeah.
So the case presentation is by Dr. Yasmin Kanagavel. He's an MBBS student at Sri Ramchandra Institute of Higher Education and Research at Chennai. The case will be moderated by Dr. Ranjit Kumar Manoharan, who is a consultant pediatric neurologist at Srihar, Chennai. Yasmin,
Yes, sir.
please go ahead.
Can everyone see the slides?
Yes, you are audible.
My name is Yathwin. I am an MBBS intern. I'll be presenting this case presentation under the title Unseen Danger, a rare genetic cause of SUDEP. I have been guided by Dr. Ranjit Kumar Manoharan, consultant pediatric neurologist epileptologist at Srihar. Clinical presentation. A two-year-old girl presented with a 2-year-old girl of non-consanguineous parentage presented with profound developmental delay, floppiness, generalized seizures, and dystonic episodes. The parents also complained about sleep issues, especially associated with sudden awakening with the dystonic episodes. Here, you can see this video of the child having a dystonic episode. The child is clearly emaciated and had not developed neck folding. You can appreciate the generalized dystonic and poriform movements.
Yadvin, you can move to the next
Yes.
videos.
Here also you can appreciate a mixed movement disorder with extreme dyskinetic movements. Here the patient is having an episode of status dystonicus. The patient was also subject to consideration for deep brain stimulation, but it was not performed.
Yes. Yeah, you can go to the next. Yeah.
Investigational diagnosis. MRI brain and MR spectroscopy showed a normal study, with the basic metabolic workup also showing no abnormalities. An interictal EEG was also performed, which also did not display any abnormalities. No seizures were also captured during the recording. A clinical exome sequencing was sent for the patient, which revealed the GNAO1 mutation, which is pathogenic variant associated with neurodevelopmental disorder with involuntary movements, developmental and epileptic encephalopathy type 17. The patient was subject to treatment for the seizures with oral levetiracetam, and the seizures became well controlled. They were well responsive to the anti-epileptics provided. Aftermath, though, the mother had left the child in the room alone for 15 minutes after the patient had come for the review. On coming back, the child had mysteriously died. There was no evidence of any preceding seizures, aspiration, or status dystonicus. To our knowledge, SUDEP has not yet been reported till date in association with GNAO1 variants. As a take-home message, the key takeaway is that in any complex neurological disorder in children, surveillance is required as SUDEP remains a possible clinical outcome, even in those genetic epilepsies which are well controlled, even with antiepileptics. Thank you.
Yes, Ranjit.
Yeah.
Ranjit, would you like to add anything?
Yeah, yes, sir. Can you hear me?
Yeah.
Yeah, thanks for the opportunity to present. So GNA1 is a common gene which can present both with movement disorder and epilepsy.
Stop sharing the screen so that we can see
Yeah.
full screen photo.
Yes, ma'am.
So GNA1 is one of the genes which is reported to have movement disorder as well as epilepsy. And it is like in this case, we had clearly epilepsy, which was distinct from the dystonic episodes the child had, and it was well controlled with oral levetiracetam. So for the dystonic crisis and status epilepticus, we had actually proposed DBS because GNOA is a primary dystonia condition which responds well to DBS. It could not be performed immediately due to logistic issues. So we were arranging for crowdfunding and all. So one sudden day, the parent reported that the mother has left the child alone in the house and she went out for an errand like 15 minutes. And when she came back and saw, the child was like dead. That's all they said. So we presume this is a case of SUDEP and possible SUDEP, although we can't do any further confirmatory studies. And I discussed this case with Dr. Karolina Gorodersky, movement disorder expert from Sick Kids. She said she has not seen a case of a GNOA or other primary movement disorders with or without epilepsy with SUDEP. That's what we thought it is interesting to share.
Yeah, so it's an interesting case. Yeah, it will satisfy the criteria for possible SUDEP. Of course, we don't have more data, and of course, a postmortem was not done. So that will be just a possible SUDEP. Yeah, it's a very interesting case, and the movement disorder was very well brought out in the videos. So thank you for that case. Any comments from the experts about this particular case? Dr. Rajesh, Dr. Kothari, any comments would you like to make about this particular case of dystonia, chorea, movement disorder, and epilepsy? And
Thank you. Thank you for presenting this case. I cannot really say that this is something directly related to SUDEP, but we know that all patients with developmental delay and refractory epilepsy are at increased risk of SUDEP. Since the postmortem was done, we cannot really say that this was a definite SUDEP, but interesting case. And with the advent of advancement in epilepsy genomics, you are seeing a lot of pathogenic mutations. And if you ask even an expert in movement disorder, they may say they may not have seen the case. Probably they will see that in the coming year. So interesting. And just more importantly, my take-home message is that all bad shapes, even in a patient with epilepsy, is not seizure. So thank you for bringing that, but SUDEP can be part of any epilepsy.
All I would say is two things. One is that when we report EEGs in our LTM unit, we usually do record whether there is any EEG suppression after the seizure. And that goes as part of the report, which helps in giving a prognosis of SUDEP risk for anybody who sees it. So I think that's an important thing. I don't know if that was observed over here or not. That gives the SUDEP risk higher. And if it is more than 50 seconds, the risk is even more higher. In such patients, if we do transcutaneous CO2 monitoring and it goes up after a seizure, that's another high risk for SUDEP. So those are my 2 points, objectively assessing. And again, I just was thinking in a comment to Dr. Mary's issue about how it is difficult to counsel in the Indian population. But I think in the Dravet population and in the LGS population, where especially LGS with tonic seizures, I think the counseling should be done because this is the highest risk. If you have refractory epilepsy in LGS, or if you have a Dravet, then you should counsel for SUDEP because the risk is highest in these two populations. In Dravet, it can go in 1 in 100, and in LGS with refractory seizures, it can go in 1 in 100. So that's a pretty high number.
Yeah.
Yeah, that's a good starting point to start with, at least for our population. So when you select some of the highest risk patients, so we can start counseling those patients before we go on to other drug-resistant epilepsy.
Yeah, the other ones like SCN8A, ARX mutations, some of the STXBP1, those are some of the high risk SUDEP ones. If you have a KCN mutation, those are the high risk that you should counsel more aggressively.
So my 2 cents on counseling is any disclosure about any risk, there is an art and there is a science. So the science part is we talk about all the adenosine, serotonin, all those are good. The art part has got a huge cultural, historical, and linguistic underpinnings. So you cannot ignore them. So I sit in Canada where my new consultation is 1 hour and my follow-up consultation is 30 minutes. And with that in my mind, I cannot ask Dr. Miri, who sees like so many patients, because I had been in the government medical college service way back. What is your priority? Is your priority saying that please take the medicine, these are the side effects of the medication? This is your diagnosis, these are your investigation you should do, and in the event of an acute seizure, what should do? Well, by the time you finish this, I think there will be 10 patients who will be knocking at your door. So I cannot really translate or generalize my findings from Canada to India. But that said, we always say we can always make stepwise progress, and that is known as opportunities for discussion. What are the opportunities for discussion? If somebody is deliberately not drug compliant, that is one to start. The second one is if they cry in your room, they are really this elephant in the room. They are worried about the death. So probably SUDEP is not about telling them the risk that you are going to die. SUDEP is more about reassuring them that the risk is here. So even in a child with absence epilepsy, I do because they are worried. And they say that, well, it is more reassuring. So it can be only a stepwise, but with this enormous number of patients, I don't know how it can be implemented, but in an ideal situation, I would agree with Dr. Kothari that we should.
I think
Take Dr.
we will have-
Kothari's advice. In a few
Dr.
months'
Mary,
time, when I retire from government service.
No, we're
Retiring
not
soon.
waiting for your retirement. No, what, Dr. Mary, not after your retirement, but before that also. I think
Okay.
what suggestion Dr. Kothari is saying that we prioritize and we ensure that we are going to tell them, and we can also make like we have some 60, 70 patient information booklets, but we don't have anything on SUDEP. We have made around 60, 70 patient information booklets in Hindi and English, another regional language. So, but we can make one on SUDEP also and keep, and it can be in the EEG room also. So like we can do when we have to we understand we have to prioritize giving them medications, and I think the humanistic touch has to be there very importantly. It's not there in our country, so it has to be put, and I think we can start off doing it proactively. And obviously we can't do it in that outpatient, but our pediatric neurology nurse who's going to be there can be there with the pamphlet, can be said, we can make out, we can just take small steps. It's not only when you go to corporate, you should make it in the government setting. Ensure before you retire. I think that will be important. Suresh has not said anything in Gosh what they are doing.
No, yeah, I mean, I mentioned earlier, we struggle as well, even with the luxury of having longer appointments. It's kind of difficult to incorporate the communication around this. And I completely understand the challenges in India because, yeah, having trained there in pediatrics, kind of seeing hundreds of patients in the outpatient, I completely kind of understand that kind of having it's a much lower priority compared to immediate kind of medical management of seizures and other issues that are active. Having said that, I think like Dr. Kothari said, it's really important to target certain patient populations. So it's not ideal, but then at least you need to be practical and target those with high risk ones. And as it's already been said, being opportunistic. So it may not be possible to have that conversation in outpatient clinic, but you could use your, when they get admitted for your inpatient kind of monitoring, for example, or if they're coming for ketogenic diet clinic or, any other opportunity where you have a bit more time to go through, and the parents will probably be a bit more receptive as well because they have time and there is appropriate setting to have that conversation. So that's something that could be thought of. The other thing I was thinking was whether, again, it comes down to practicalities, whether you could have like a group educational session. So, bring all your difficult epilepsies together for a educational day on a Saturday morning or something. And then, invite all the parents with difficult epilepsies, and there you have the time. You don't have to spend time with each parent, where you have 50 or 100 patients and parents, and you could do a mass education and at the same time distribute leaflets so that you save time, but you kind of targeting the right patient population to provide the information.
Can I just make a point on this issue?
Yeah.
I think you made a very good point. So mass education. So two things. One, putting a simple pamphlet in the OPD for you and saying in different dialects common in that area about SUDEP, what is SUDEP, what is the risk, how can you prevent it, how can you recognize it, will help. While the patient is sitting, the families are sitting in the waiting room, waiting to be taken in, they can read about these things. That's one. Two is mass education. If you get one famous person on TV whose kid has, or whose somebody has died with SUDEP, and you advertise it through TV, it makes a huge impact. I'll give you an example. Over here, people in the Western world know David Axelrod. He used to be the Obama media person, and his daughter has SUDEP. And so his wife, Susan Axelrod, started CURE. The CURE is a project for curing epilepsy. And just having such a famous person, and this was done because their best friend, the daughter's best friend, died of SUDEP. So having that, a lot of SUDEP awareness improved. Also, we had a death from a Disney character in California. That suddenly brought the SUDEP into the front end. So I think having this TV coverage for these kind of things really has a big impact on this problem.
Yeah, thank you, sir.
So, Dr. Gulati, I have a difference of opinion because my research is primarily on qualitative research with the patients with epilepsy and parents of children with epilepsy. So the question is, what do they want to hear? They want the exact risk of SUDEP for that particular patient, and they want it to be part of the comprehensive epilepsy education. So I strongly recommend against having a specific pamphlet for SUDEP, because you are just conveying a negative message. On the other hand, if you have a epilepsy information pamphlet and SUDEP is part of that, that will be more appreciated, because in their mind, what they are thinking about is always SUDEP. Because you don't want to hand them, and my research I already published, they don't want to have a brochure on SUDEP. So we had a organization, SUDEP Aware, they had this pamphlet and we blocked that in our house. We said we appreciate their work, but we want it to be included within the comprehensive epilepsy education, because our aim is not to convey SUDEP. We want to convey a comprehensive education about epilepsy, and SUDEP is just part of that. So I have a difference of opinion, but I hear everybody's.
So what will happen? What will happen in this issue is New York has already done it. New Jersey is considered doing it. California will do it immediately next. So in the US, unlike in Canada, it'll become almost a mandate to have a SUDEP pamphlet in every clinic or ER with handles patients with epilepsy. And things will change because I think it's a different opinion again, but this is my opinion. And we do it, and we have been doing it for the last 3 years since it became a law in New York State.
Yeah,
Lakshmi, we have only 5 minutes. Can you just go through the questions and just ask the gist of the questions?
Yes, ma'am. There is an audience question. Dr. Velmurugan has asked about a specific patient. There's a 3-year-old child with SCN2A epilepsy who had apnea, and although the child seizures were fully under control, but irrespective of the seizure control, child continued to have apnea, and the child was on carbamazepine. So the parents were specifically insisting on tapering and reducing carbamazepine. So the question is there a risk of SUDEP in this SCN2A patient with apneas unrelated to seizures, and carbamazepine should be continued or discontinued? Any of the experts, Dr. Rajesh or Dr. Kothari, Dr. Pujar, or anyone?
So we should know whether SCN2A. Go ahead. Sorry. Go ahead.
Go ahead.
No. Please. You're the speaker of the day, please.
Any patient with a drug refractory epilepsy is at increased risk. On top of that, ictal SUDEP is a very romantic concept, and we have possibly even a hypothesis. Does not necessarily mean that all the SUDEP need to follow seizure as. So in that context, if an effective drug is being withdrawn, your chance of having refractory convulsion is high. That is going to increase the risk of SUDEP. So if you ask me yes or no question, like in the court, answer is yes. But I think there is further nuance.
Yes, Dr. Kothari.
We need to know whether the SCN2A is a gain of function or a loss of function, because
It's not
that
mentioned
changes the that changes the prognosis dramatically. That's number one. Two, in the paper that Oren Devinsky published in the UGrant, and we were part of that thing, there were several patients who had seizures even 5 years after being seizure-free off medications. So we cannot say 100% this will not happen, or it could happen. I think that risk has to be discussed. I think if you're seizure-free for 2 years, even if you have SCN2A, it is okay to withdraw medications if your EEG is normal. If your EEG shows generalized or multifocal spikes, then it's a different discussion. So I think that has to be discussed in multiple layers, just not on one point.
Yeah, agreed. I think that's all the questions we have from the audience.
No, there is in Q&A, please. There are 3 questions.
Oh, sorry. Okay. So
I responded to one of them already.
Yeah, the most important question is, could it be a medical legal issue if it is not disclosed by the doctor?
Yeah, so
already depends
the
on
person-
the region.
The person who has done maximum work on this is Dr. Beran from Australia. So he published about 14 years back something known as material risk. And material risk is a term which we used in medicine when a reasonable person would change the course of action when a fact is presented to them. So initially, those period, the question was, well, you inform about SUDEP, so what? Are you going to change the outcome? So in those days, I think people were saying that there is no material risk. But now we know that there are identifiable risk factors for SUDEP, and maybe it can be prevented to an extent. So then there could be a material risk. If you read the book, if you just Google it, is free, Global Conversation SUDEP, you see very interesting medico-legal cases about SUDEP. And in those books, none of the doctors were found culpable. And the study from Scotland, I think there was an inquiry which has got no legal bearing, but there was a recommendation that it should be disclosed. But if there is a law in the States, you know that the mother of all medical litigation is United States. So Dr. Kothari, so probably it is going to come very soon.
No, I think only in the state of New York, it would be legal, because it is a criminal offense not to discuss and report it in the EMR. If a patient of SUDEP dies, I'm positive that the governor's office will audit that chart. And if that is not documented, then I don't know what's going to happen. It has not yet happened in the last 3 years. Since October of 2021, it was passed, but who knows? I don't know the answer.
So there is another question of, is there any role for long-term cardiac monitoring? I think it is about the Holter monitoring or any other basic baseline ECG changes that can predict SUDEP.
I leave that to Dr. Kothari because he has both epilepsy as well as sleep.
So you know that, as you have discussed correctly, that it is a multifactorial thing. There's cardiac abnormalities, there is respiratory abnormalities, there are other abnormalities which we don't know of, but cardiac is one of them. If you have a genetic mutation in the potassium channel or calcium channels, which are cardiac genes, then the risk is higher. Having said that, we have put pacemakers only when there is an asystole in a documented seizure disorder, which leads to asystole. Then yes, we put a re-entry pacemaker and that's done. If that's not done, it's a medical legal case. But I don't think we can keep on monitoring them on a continuous basis.
So the only group of patients we tend to do that is for Dravet patients or any other kind of genetic mutations that are co-expressed in brain and heart. So because they have increased risk of cardiac arrhythmias, but apart from that, it's impossible to do it on other patients.
So one last question. There's a question about lamotrigine use and unmasking Brugada syndrome or any other cardiac arrhythmias or other abnormalities.
So several years back, a risk about SUDEP was published, and they mentioned that women on lamotrigine have got an increased risk of SUDEP. That data was reanalyzed by Dr. Hestroper, who passed away, I think, a couple of years back, and that was statistically not correct. And now the belief is that lamotrigine is unlikely to add to the risk of SUDEP. That said, if you have a pre-existing cardiac condition, there are several drugs that affect your conduction system. So if it is documented, we should be careful.
Okay, so that answers the
Thank-
questions.
Yeah,
Over to you, ma'am.
thanks. Yeah, thanks. Now, as customary, take-home messages. So the speaker gives the take-home message first, followed by the experts. So take-home message for the entire session. Rajesh.
Well, SUDEP is a phenomenology-based definition, and it needs a revision to incorporate the mechanism as well. The ILA is working on that. The most romantic concept following a post-convulsion SUDEP is the adenosine serotonin mechanism, because that gives us some ability to intervene, at least in the future. Third and foremost is prevention of SUDEP. The most important thing is reduce the nocturnal convulsion. For patients with epilepsy and parents of children with epilepsy really want to hear about the risk of SUDEP, and it could be quite reassuring, and that does not add to their long-term anxiety. And that is my take-home message.
Thank you. Thank you for an amazing talk and amazing discussion, Dr. Kothari. Then I'm coming to Suresh. Then
I'm going to put the audience is pediatric and I'm a pediatric neurologist. So I'm going to put my pediatric hat and say very categorically that unlike previous beliefs, SUDEP happens in children at the same prevalence and risk as adults, 1 in 1,000. So all pediatric neurologists need to be cognizant of that, because I've had several of our senior pediatric neurologists say, that SUDEP is an adult disease. It doesn't happen in children. Well, it happens in children. That's my message.
thank you. Suresh.
So my suggestion is to, with regards to SUDEP communication, is be practical, take into consideration the limitations and the options that you have within your setting to provide that information. Be opportunistic, use the opportunities where you can kind of provide the information. Don't wait for clinic appointment. And also have a structure within your kind of, have a structure, how you're going to provide the information for low risk versus high risk, so that, it's kind of tailored to the patient risk, but provide the information in everyone, sometimes reassuring, sometimes to the advantage of making sure that the patients and parents comply with the advice that you're providing.
Thank you, Suresh. Mary.
In India, I think we should start following up developmental epileptic encephalopathies and try to find out what is the real mortality, find out the proportion of SUDEP among them, so that we can learn from ourselves what really is happening.
Thank you. Thank you. Lakshmi, want to add something?
No, I think we need to ensure compliance, medicine compliance, and we need to talk about SUDEP a bit more often than we do currently.
Absolutely. Mahesh?
I agree with the comments. Especially with the DEs, I think we should always take a visit. Like drivers.
Yeah, I think it is there. We are just not looking for it because we are not able to get in the scenario and get the thing. And autopsy is very difficult to get in our patients most of the times. But then we'll have to do and look about it, and yes, start counseling and in those high risk ones to begin with for logistic reasons. Yes, and I think I want to appreciate Yathwin, an MBBS student, and in turn presenting a case in a pediatric neurology forum. Yathwin, you presented very well. Ranjit, you're mentoring very well. Congratulations, Yathwin. Actually, Asmita has not shared your certificate on screen, but she will be mailing you a certificate of appreciation as usual. Thank you so much. Thank you everyone for a wonderful session. And we would invite you for the AOCCN next year in New Delhi, 16th to 20th of September, Yashubhumi, New Delhi. Thank you so much.
Bye-bye.
Thank you.
Thank you.
Thank you.
Bye-bye.
Have a great
Thank you.
day. So great day to our North America people, and good night to here, and after good afternoon also. So we had people from different time zones. Thank you so much. Bye-bye.
Bye-bye.
Bye. Bye.